Hello and good day everyone! As second-year students who have learned vital information about maternal and child care, which are an essential part of our nursing practice, we are going to utilize our skills and knowledge regarding nursing informatics in order to relate to you one subtopic on NCM 109 that we think could be helpful for student nurses to further learn and explore while watching this flipped video. So to formally start our presentation, we are the third group and we are going to discuss and further expand the topic on vomiting in pregnancy, or what we call in the medical setting, the hyperemesis gravidarum. To begin with, hyperemesis is called severe and excessive nausea and vomiting during pregnancy, which leads to electrolyte, metabolic, and nutritional imbalances in the absence of medical problems. It generally strikes between the 4th and the 6th week of pregnancy and may be at its worst around weeks 9 to 13. The vomiting is so severe that most women are unable to go about their typical daily activities. With this, a mother can experience pernicious or persistent nausea and vomiting that is observed in her second trimester and that can be prolonged beyond 12 weeks, severe dehydration, and weight loss. It occurs at an incidence of 1 in 200 to 300 women. The condition might be caused by rapidly rising serum levels of hormones such as the human chorionic gonadotropin or the HCG and estrogen. Some studies reveal that it is associated with Helicobacter pylori, the same bacteria that cause peptic ulcers. Extreme nausea and vomiting during pregnancy might indicate multiple pregnancies or the H-mode. In addition, the suggested causative factors include metabolic or nutritional deficiencies, more common in unmarried white women and first pregnancies, family-related stress, and thyroid dysfunction.
For the signs and symptoms of hyperemesis, first and foremost is nausea and vomiting, wherein anything taken orally is rejected. First, feeling dizzy or confusion, headaches, lightheaded, faint and irritability. Losing more than 5% of body weight, becoming dehydrated with signs of dehydration such as dark urine and dry skin, electrolyte and nutritional imbalances, increases salivation, rapid heart rate, low blood pressure, yellowing of the skin and eyes, decreased urination, and sleep disturbance.
For the assessment of the hyperemesis gravidarum, there are following observations. First is having severe nausea and vomiting. With hyperemesis gravidarum, a woman's nausea and vomiting are so severe that she cannot maintain her usual nutrition. Second is elevated hematocrit. So she may show an elevated hematocrit concentration at her monthly prenatal visit because her inability to retain fluid has resulted in hemoconcentrations. Third, another observation is having low sodium, potassium, and chloride. So concentrations of sodium, potassium, and chloride may be reduced because of her low intake, and hypokalemic alkalosis may result if vomiting is severe. Polyoneuritis. In some women, this is present because of deficiency of vitamin B that develops. Another is having weight loss, or another one is weight loss can be severe. Lastly, urine test for ketones. Urine may test positive for ketones, evidence that a woman's body is breaking down stored fat and protein for cell growth. So if this is left untreated, the condition is associated with intrauterine growth restriction, or what we call the preterm birth, if a woman becomes dehydrated and can no longer provide the fetus with essential nutrients for growth. So always try to determine exactly how much nausea and vomiting women are having during pregnancy. So there are some of the questions to ask a woman to describe the events of her day. First, how late into the day did the nausea last? Second, how many times did she vomit and how much? Third, what was the total amount of food she was able to eat?
Now, these are the various diagnostic tests that can be performed in order to determine whether or not the pregnant woman has hyperemesis gravidarum. First is clinical evaluation. Clinicians suspect hyperemesis gravidarum based on symptoms, and serial weight measurements can support the diagnosis. Next is urine ketones. Patients are routinely tested for the severity of nausea and vomiting during pregnancy by checking ketone levels in the urine at presentation. Later, reduction of the ketone levels is a marker for improvement following treatment. And next is serum electrolytes and renal function test. Serum electrolyte imbalances may result in hypokalemia, and potassium abnormalities have been reported to increase the mortality of women with hyperemesis. And lastly is the exclusion of other causes such as dehydration. If hyperemesis gravidarum is suspected, the following are assessed and measured: thyroid-stimulating hormone, serum electrolytes, blood urea nitrogen, creatinine, aspartate aminotransferase, alanine aminotransferase, magnesium, and phosphorus.
So these are the following nursing diagnoses with its nursing interventions. For the first diagnosis is the risk for deficient fluid volume related to vomiting secondary to hyperemesis gravidarum. For its nursing interventions, the nurse must measure the input and output including the amount of vomit, assess the skin or oral mucous membranes, blood pressure, and temperature for signs of dehydration, administer IV fluid to increase hydration, give small amounts of clear fluid if there is no vomiting after the first 24 hours, and to measure the weight daily and compare it to the standard. The second nursing diagnosis is the imbalanced nutrition less than body requirements related to prolonged vomiting. For its interventions, the nurse must give small quantities of dry toast, crackers, or cereal if she can continue to take clear fluid. Give enteral or total parenteral nutrition if vomiting returns at any point as prescribed by the doctor. Remind the patient to use prescribed prenatal vitamins. Collaborate with the nutrition department to set nutritional goals and to assess oral hygiene and personal hygiene.
And now for the nursing interventions, women with hyperemesis gravidarum may need to be hospitalized for about 24 hours to document and monitor their intake, output, and blood chemistries and to restore hydration. All oral foods and fluids are usually withheld for the first 24 hours. In addition, radiographic studies may be appropriate to rule out alternate diagnosis. Intravenous fluid, example is 3000 ml Ringer's lactate with added vitamin B, may be administered to increase hydration. An antiemetic such as metoclopramide, Reglan pregnancy class B may be prescribed to control vomiting. If there is no vomiting after the first 24 hours of oral restriction, small amounts of clear fluid can be started and the woman can be discharged home, usually with a referral with home care. The evaluation should include urinalysis to check for ketonuria and specific gravity, in addition to a complete blood count and electrolyte evaluation. Thyroid tests, lipase, and liver function testing may also be complete to evaluate for alternate diagnosis. MRI may be used to assess for alternate diagnosis such as appendicitis. Obstetrical ultrasound may be considered to rule out multiple gestations, ectopic pregnancy, and gestational trophoblastic disease depending on the patient's history and prior obstetrical evaluations. If she can continue to take her clear fluid without vomiting, small quantities of dry toast, crackers, or cereal may be added every 2 to 3 hours, after which the woman may be gradually advanced to a soft diet and then to a regular diet. If vomiting returns at any point, enteral or total parenteral nutrition may be prescribed to ensure she receives adequate nutrition.
Just like the nursing interventions, therapeutic management is also needed in order to ensure optimal comfort to the client, which can be done by the following. So we have hospitalization, withheld oral food and fluid, administering IVF, antiemetic, measure input and output and amount of vomitus, and if there is no vomiting within 24 hours, the client may start small amount of clear fluids, giving dry crackers, dry toast, or cereal, and be added every 2 hours. So, and if vomiting returns, total parenteral nutrition is used.
And lastly, This nursing care management should be done in a timely manner to give competent and functional service to the client, which are vital for the recovery process. So first, ensure that the client has no oral intake until vomiting stops. Attend to client's emotional and psychological needs. Record input and output. Advise solid food feeding once vomiting has subsided. Administer antiemetics as prescribed. And administer intravenous fluids. And if not treated immediately, this could affect the growing baby and it could lead to preterm birth and intrauterine growth restriction.
Obviously, the discussion about hyperemesis gravidarum has been loaded with too much information. That is why we have this acronym in order for us to remember the key points necessary in learning about this topic. So, the acronym used is EMESIS. E for exaggerated nausea and vomiting beyond first trimester. M for metabolic alkalosis, hypoproteinemia. E for electrolyte, fluid, vitamins and minerals replacement and nutrition. S for skin turgor and mucous membrane assessment for dehydration. I for ingest blunt solid foods. And S for strict hygiene and bed rest.
Lastly, these are our presentation sources. Thank you for listening and have a good day.